So thank you. Dr. Shibikom is an adult and pediatric cardiac surgeon working at the Cardiac Center. He will be presenting us about prosthetic valve endocarditis. We're very happy that you had time to spare for us. You can start your presentation, Doctor. Thank you.
Thank you so much for Ethiopian Society of Cardiac Professionals, as well as Etena work for this opportunity, so that we will have a chance at least to have presentation with our colleagues and as well as with our all participants. So I think, can you hear me well? I think voice is okay. I think there's no problem.
Yes,
so far.
Yes, we can hear.
All right. So I'll be discussing about prosthetic valve endocarditis. Thank you for your kind introduction as well. So prosthetic valve endocarditis is now becoming of a concern nowadays because of we're increasing the number of surgeries, and especially with the valve surgeries. With that, we'll keep on seeing those cases. So first, I would like to tell you about one real case scenario, which was in 2018. It was a very unfortunate year for this patient. He was a 33-year-old male patient who underwent mitral valve replacement in the month of January 2018 for rheumatic heart disease in India. So at that time, they implanted a tissue valve, because at that time he was having sinus rhythm. Most probably that is the reason that they put the tissue valve. And the patient was insisting on not taking warfarin as well. So after 5 months of the surgery, same year in 2018, he developed prosthetic valve endocarditis. It was diagnosed here in Ethiopia. So after a lot of negotiation, finally the patient got convinced and he went back again. And they did redo mitral valve replacement, again using tissue valve in June 2018. So it is in the span of 6 months that he is having all those things. And then again on on the 11th month, 2018, the same year, he developed again prosthetic valve endocarditis. But even that time, he was quite reluctant to take any of the medications. So we're having hard time actually to convince him to continue the medication. He was telling us that other options are there. Without even opening my chest, they can implant the valve. So he was convinced about those things. And finally, he was taking time, but the disease was really progressing very fast. And almost the valve was actually the second evaluation. We saw that it was put by translocating towards the left atrium, and he was having severe regurgitation, and he couldn't make it actually. Finally, he passed away the same year. So I would like to show you some echo pictures which we could get from his initial diagnosis. So you can see here, he has got this vegetation. This is the mitral position. Okay, you can see the vegetation here. Okay, there's another video also where we took a static image. You can see the size of the vegetation. It's around 8 by 8 millimeters. So it was a big one. We couldn't save the second episode. During the second episode, we couldn't redo the transesophageal echocardiography. Later on, diagnosing him, he was refusing to take the medications. So unfortunately, he couldn't make it. So it's not a simple disease, actually. So finally, he couldn't make it. The patient was, in the initial one, he was having more of stenotic lesion. And the second one, it was becoming more of regurgitant, actually. So what do you mean by prosthetic valve endocarditis? So what does it include? It includes either it is repaired or it's replaced, okay? Usually we think of prosthetic valve endocarditis when the patient is having the replacement, but that's not the case, okay? So it can happen even with repaired valves, because during repair also, We use different synthetic materials, sutures, pledges. Okay, so all those things, rings will be there. So with that, also patients can develop prosthetic valve endocarditis. But there is also another terminology, which is polymer-associated infections. Those are infections due to devices or lines which are placed inside the heart, but they don't have any attachment to the endocardial structures. For example, the commonest thing that we put is central venous catheters. So those can get infected, and they are also one of the sources for prosthetic valve endocarditis and other forms of infection as well. So we'll see it subsequently. So cardiac surgery, it was started in the early 1950s, the open one, but valve surgery was started in the early 1960s. So since 1960s up to now, there are a lot of improvements on the valve designs. So the aim is to get the best or the ideal valve. But so far, we didn't get any ideal valve. So when we say that we have got an ideal valve is one, it has to have excellent hemodynamics. So if you have seen the most post op patients, especially on the aortic position, they tend to have a higher gradient. The other is a durability issue. So when you compare mechanical versus tissue valve tends to have a shorter durability. The other is with thrombogenicity. So we need to have a valve which is thromboresistant. So far, tissue valve is having a better one. And implantability, how easy is the implantability? Nowadays, doing TAVI. So we'll see the outcomes in the future, and risk of infection has to be lower. But so far, we didn't get any valve that will really fulfill those criteria. So as to the incidence of prosthetic valve endocarditis, it will comprise for 1/5 or around 20% of infective endocarditis are due to prosthetic valve endocarditis. So we can't underestimate this thing. This is a major figure. And after you do valve replacement, okay, patients will have around 0.1 to 2.3% per patient year of developing infective endocarditis. When we say per patient year, it means we will sum up the number of we'll calculate the number of the patients, and then we'll multiply by the number of years that they are still those who are really alive. And then when this episode happens, we multiply that, and we'll divide by the number of the patient years. So the incidence is going to be around 0.1 to 2.3% per patient year. And at 10 years, the cumulative risk is around 5%. And when we classify prosthetic valve endocarditis, we classify it as early and as well as late. So, or later on the slide, there is when do we say early? It means that the infection has occurred within 1 year of surgery. Late is after 1 year. So the prognosis tends to be worse if patients develop early prosthetic valve endocarditis. Why? The obvious 3 reasons are: 1, the clinical setting. Okay, the infection is usually acquired in the hospital setting. Even if the patient is discharged, usually the infection has happened while they are in the hospital. Okay, so the clinical setting is within the hospital setting. That makes the infection even more worse. The type of microbe is also going to be a difficult one. And, majority of patients with early prosthetic valve endocarditis tends to require redo operation. So because of that, their prognosis is going to be poor. So if you see mortality, through years, the good thing is that mortality is coming down. So in 1970s, that means just after a decade, when valve starts to get replaced, the mortality was around 56 to 60%. But now, in the beginning of the century, it has dropped to around 23%. Why? Because we're starting to diagnose them early, And myocardial management is getting better with the better use of cardioplegia solutions. And surgical technique and approach has improved through years. That's why we are getting a better outcome for patients who undergo surgery for prosthetic valve endocarditis. And when we see medical versus surgical treatment, those patients who are treated surgically after developing prosthetic valve endocarditis tended to do better than those who are managed medically. So you can see, in medical treated patients, mortality is around 26 to 75%, so it is quite wide one. But in surgical treated patients, around 23 to 40%. But even if we manage those patients medically, at some point during follow-up, patients who are managed medically still do require surgery because of progressive prosthetic valve dysfunction. So as I have said previously, we classify prosthetic valve endocarditis as early versus late. So 1 year is a time cutoff. So early is within the first 1 year, late is after 1 year after surgery. So mind you, this infection can happen starting from the day of surgery as well, because it can be acquired perioperative. That means even preoperatively, if you don't work up for other distant sites of infection, intraoperatively, post-op, 1 hour ICU follow-up, okay, on immediate follow-up, all those things are the areas where patients will get those infections. And if you take a patient who is having effective endocarditis, and if you take them for surgery, okay, because of the indication for because of the indications that they develop during the course of treatment, risk of developing early prosthetic valve endocarditis around 5%. And it will be even worse if the organism was not identified or the treatment that was given is incomplete. So if you see those two terminologies, those are really the problem in our country. Usually the organism can't be identified. We keep on sending cultures, and now and then it turns out to be negative. And treatment-wise, you have to give them intravenous treatment, and patients either can't afford, or because of issues with IV line or different reasons, patients will not complete their treatment or compliance issue. So risk will be even more than 5%. So if we compare the late prosthetic valve endocarditis, mechanical versus tissue valve or bioprosthesis. So if you take the mitral valve position, if we replace mitral valve with tissue valve, okay, risk of late prosthetic valve endocarditis around 0.49%. And in the aortic, when the mitral position, if you use mechanical prosthesis, the risk is around 0.18%. So less than half, that means. If you take the aortic position and if you put aortic valve, tissue valve in the aortic position, the risk of late prosthetic valve endocarditis is around 0.91%. But if we put mechanical valve in the aortic position, the risk is around 0.27%. That is less than 1/3. And if you have patients having multiple implants, mechanical valve, the risk is around 0.29% per patient per year. So if you see it generally, tissue valves, they tend to generate faster, okay, shorter length of stay, and the risk of infection is high as well. And you can also see, we have done one research by our team to see the outcome of surgical repair versus replacement being done either using tissue valve and mechanical valve. The same is true in our setting, okay? Tissue valves are doing worse, actually. So pathogenesis, how do patients develop prosthetic valve endocarditis? So the mechanism is different, whether it is a mechanical valve or is it a tissue valve. So in mechanical valves, usually the infection starts at the sewing cuff, or if there's any clot near the sewing ring. Because if you see the mechanical valves, the leaflets are made of pyrotic carbon usually nowadays. Okay, it's a metallic one, it's an alloy. So it's unlikely for a clot to be formed unless and otherwise patient has got issues with compliance with their anticoagulants. So usually the infection starts at the sewing ring. That means valve patient annulus interface area. That is the area where it starts. When you look at tissue valve, in tissue valves, it's different. It's just like a native valves, endocarditis. So it starts to affect the cusps first. Okay, the sewing ring is usually more resistant, but it doesn't mean that it doesn't involve it. If it involves the sewing ring, then it will be just similar to the mechanical valve. And let's say that the patient didn't develop early prosthetic endocarditis, then lately, they will have degenerative changes because of their inherent nature. So once they develop the degenerative changes, then those foci for degeneration are also areas for infection as well. So even if they somehow, didn't develop early prosthetic endocarditis lately because of degenerative changes, those areas will be also a good foci for infection. So what are the causative organisms which are responsible for prosthetic endocarditis? In our setups, we don't have really studies because even if we send cultures, even from the specimen itself, it turns out to be negative. So, but from standard textbooks, we see that streptococci and enterococci are less frequent as compared to the native endocarditis. So what are the commonest microorganisms which cause prosthetic endocarditis? Mainly staphylococci and the Hackett group and fungi. Those are the main causes for prosthetic endocarditis. So when you look at early prosthetic endocarditis, the most common source of bacteremia are wound infection. So, usually surgical site wound infection, the reasons are depicted as local causes as well as systemic causes. But from the local causes, I tell you, it's mainly due to the surgery. Okay, how is the tissue handling, how they are closing the wound, okay, how they are managing later on. So we have to really capitalize on having a clean and nice wound, because if that gets infected, then the risk of developing prosthetic endocarditis is very high. The other is urinary tract infection. So usually in the preoperative workup, it's one of the baseline investigation. We do urinary analysis. If there is infection, we have to treat it first. Pneumonia, it's another known cause so as a source of early prosthetic endocarditis, and intravascular catheter infections, or as I have said previously, polymer-associated infections. So in late prosthetic endocarditis, source of bacteremia are skin infections, orodontal infections, abdominal infections, and invasive dental procedures. So I would like to point out those two, the second and the fourth bullets. Usually, when you send patients for dental workup, sorry, either preoperatively or postoperatively, the tendency in our country is to push those patients back. Okay, so we have to really work more on that area, because source of infection for native as well as prosthetic endocarditis lately is because of dental infections. So we have to really team up with really what we have to do with the treatment as well as with the management of their anticoagulation. Usually it is a debatable area in our country, but it is clearly written on the guidelines. So I don't know what the limitation is. So we keep on sending, even including our personal numbers, so that we can discuss, but it's not going well. Usually they will push them back, and patients will not get the required treatment for the dental problem. So clinically, how does those patients present? Usually they have persistent fever after surgery. They keep on having this fever, which is not abating, and they will have profound anorexia. And there will be a new murmur or a changing murmur during auscultation as well. And some patients will develop different forms of rhythm disturbances, mainly heart block, because it tends to involve the surrounding tissue. And they can come up with congestive heart failure and as well as embolic events, be it to the brain or other organs as well. There are also some dramatic events. We have seen those things happening. The first thing is myocardial infarction because of septic embolies. It can go directly to the coronaries and we can lose the patient suddenly. The other is sudden death from distress venosa valve. The whole valve apparatus can embolize it. So as to the workup, so we still can use modified Dukes criteria, and just like a patient who's having native valve endocarditis, but TEE, transesophageal echocardiography, has to be done in any patient who underwent valve replacement if we suspect prosthetic valve endocarditis without any delay, because we are running against time. But even if after doing echocardiography, if we have got higher suspicion of prosthetic valve endocarditis, still negative echocardiography can't rule out the presence of those things. So we may need to do also repeat assessment. So the most important thing is the clinical judgment that will make a difference on the one. There are some sort of scanning studies which are undergoing studies. So in the future, we'll see how we can use them. So management-wise, so the basic principles are the same. So we identify the causative organism if it is possible. And then if you can't get the microorganism, then we can select the appropriate antibiotic. But we have to make sure that is it really one form of bacteria or polymicrobial? And then we will evaluate for any complications, because those complications can take us to for possible surgical intervention. So with regard to the principle of antimicrobial treatment, it's just the same as native valve endocarditis. But when you look or when you compare native valve endocarditis versus prosthetic valve endocarditis, the vegetations tended to be bigger, as I've showed you the first couple of slides. We can see the vegetations quite clearly. So what does that tell us? That means when you are selecting drug or the antibiotic for that specific patient, we have to consider the maximum non-toxic level so that we can get a maximum clearance. And as to the duration of the treatment, usually up to 4 to 6 weeks is given, but we can extend beyond that, depending on our transesophageal echocardiography finding, as well as minimum inhibitory concentration of that given drug. So minimum inhibitory concentration of a drug means the minimum amount of drug that is required to end up in having any visible growth of that given microbacterium or that like bacteria. But I'm not sure whether we can measure it within our country. So the other is the type of microbe, especially with coagulase negative staphylococci. It's a very difficult one because usually we'll end up in doing surgery as long as it is caused by staphylococcal organism. Why? Because it's quite clever bacteria, tends to produce a biofilm, which is very difficult to penetrate using our different combination of drug. It tends to form micro abscesses, okay, around the sewing ring mainly. And that's why if available, we can give them rifampin. It's part of the combination. So now the patient has come, we have somehow diagnosed him. So the next step is to take blood cultures. So the empiric treatment will be started after we send the blood cultures, just as it is true in other forms of treatment as well. Then we will send that culture specimen, then we start our empiric drug treatment. So empirically, what should we start? Then we have to consider covering both the gram-positive as well as gram-negative bacteria. So the combination will be vancomycin plus gentamicin plus carbapenem or cefepime. Now, let's say the culture came back positive. Then if they have identified a given microorganism, then let's say that microorganism is Staphylococcus. Then, if it is Staphylococcus, the drug treatment will be geared by its medicinal resistance, medicinal sensitivity or resistance. If it is medicinal sensitive, our combination will be nafcillin with oxacillin plus gentamicin plus rifampin or rifampicin. And if it is medicinal resistant, so vancomycin plus gentamicin plus rifampicin. So nafcillin or oxacillin will be considered if patient is having a methicillin sensitive Staphylococcus. If not, if it is resistant, then we'll replace that with vancomycin. The rest two are the same, so gentamicin plus rifampicin. If the identified microorganism is streptococcal, then beta-lactam antibiotic with aminoglycoside. If it is enterococcal, then we'll use penicillin, ampicillin, or vancomycin, but not cephalosporin, because cephalosporin doesn't work against enterococcus. So we will combine penicillin, ampicillin, or vancomycin with gentamicin, aminoglycoside, or streptomycin. If patients having vancomycin-resistant enterococcus, then we can use daptomycin linezolide. If the identified microorganism is gram-negative bacilli, then we combine beta-lactams with fluoroquinolone or aminoglycoside. If it is due to HACEC, then in such cases, we will use subgenerated cephalosporins. If patient is allergic to that one, we will consider fluoroquinolones. Now, let's say that we send the culture, okay, we started empirical treatment, okay, then patient turns out to have a negative culture with early prosthetic endocarditis. That means less than 1 year after the surgery. So we should consider possible infection by staphylococci, enterococci, and aerobic gram-negative bacilli. So the combination will be vancomycin plus gentamicin plus cefepime plus rifampicin if it's available. So usually in our setting, we give them vancomycin with gentamicin. Cefepime, if it's available, it will be given or patient can afford, but rifampicin isn't available. So the trend will be to combine vancomycin with gentamicin with cefepime. That is the thing in our setting. If patients having culture negative late, that means after 1 year of surgery, late prosthetic endocarditis, then we should just consider just like a patient who is having native endocarditis. So we combine vancomycin with ceftriaxone. So how do we count the number of days for antibiotic treatment? What we do is we take 2 blood cultures every 24 to 48 hours until the blood culture turns out to be negative. This works in those patients who have got a positive blood culture. Then once the patient's culture report turns out to be negative, then we start counting the number of days of treatment. Then that will be extended up to 4 to 6 weeks, even more than 6 weeks, depending on the MIC, okay, minimum inhibitory concentration, and as well as the size of the vegetation, and on follow-up echo as well. So what do we do with antithrombotic treatments? So we have to shift them from oral anticoagulant to intravenous heparin or low molecular weight heparin. There are some reservations with the low molecular weight heparins. These are more advantage in those patients who are having a lower platelet count. So because they tend not to cause thrombocytopenia that much. So generally, there are some guidelines that the level of evidences are not that much strong, so the class ones are, you have to involve the surgeon in the evaluation of patients who develop prosthetic endocarditis, because we have to decide which patients really require surgery, because it is time which is against us with regard to the surgical outcome and later complications as well. That is level of evidence, or the class of recommendations 1. So if patient has developed heart failure, which is intractable one, with a given inotropes as well as after reducing drugs, if still he's having persistent heart failure, we can consider surgery. And if they develop mechanical compression like dehiscence, then we have to do surgery. And if they develop increasing obstruction, just like our patient that we have presented earlier, so it tends to develop prosthetic valve stenosis because of the infection, then surgery is indicated. And as well as if the regurgitant lesion gets worsened. And the other is if they develop other things like abscess formation and other things, then surgery is indicated. The others are not that much strong. But if patients having uncomplicated endocarditis, prosthetic valve endocarditis, which is sensitive to a given antimicrobial treatment, then there is no place for surgery. So usually those guidelines, they really change in the course of time, because that's what we are seeing here. So we can see the level of evidence majority are level B, if not they are level C. So we have to come up with data. So data will support us what we have to actually do in those patients who develop prosthetic valve endocarditis. So guidelines will tell you what you have to do, but data will show you what you are actually doing. So if you can come up with more robust data, then you can come up with better evidences, and then we'll have a better outcome of surgery and as well as medical management. So in the indication for surgery, I would just like to summarize, as I've said previously, if patients having severe congestive heart failure, which is not responding to inotropic support, then we have to consider surgery. If patients having worsening cardiac, renal, or pulmonary function, then because initially they stabilize, when we start the antibiotic, then start to worsen, then we have to consider surgery. And the other thing is we give them antibiotic, bacteremia. That means, as we have said previously, we take culture every 24 to 48 hours to make sure that the patient is becoming culture negative. But if they are having persistent bacteremia, we have to consider surgery because we have to remove the focus. And if they develop embolization despite they are taking their antibiotic treatment, or if they have got big vegetations on echo, then because the risk of embolization is very high, in such patients we better take them for surgery rather than waiting for miracle by giving them drugs. And if there is any worsening of their intracardiac or perivalvular pathology on echo also, or if they develop any or worsening conduction abnormalities, okay, because if you are doing mitral and aortic surgeries, the conduction tissues are quite close by. Tricuspid is the same thing, okay? Only pulmonary valve is quite distant from the conduction tissue. So I beat mitral, aortic, or tricuspid, all are really close to the conduction tissue. So once they develop the infection, it tends to involve the surrounding structure, so patients tend to develop those conduction issues. If they develop annular abscess, paravalvular leak, and if they develop fast sinuses or aortic aneurysms, then we have to take them for surgery. If the prosthetic valve endocarditis is caused by fungal or brucella or late prosthetic valve endocarditis due to staphylococcus, those pathogens are not easy to manage using antibiotic alone. So we have to do surgery. The last four indications are infection with gram-negative organisms, which are poor responsible for antibiotics. If patient develops early prosthetic valve endocarditis, the likelihood that the patient will end up in surgery is very high. And if they develop valve obstruction with vegetation, we have to take them for surgery. And the conduction abnormalities, as I've said previously, we have to take them for surgery. So what do we do during surgery? The main principle is once we decide for surgery, they are going to undergo redo surgery. So there are risks associated with redo surgery. So once we get there, most important thing, the most important principle, just like any form of infection, is to do extensive debridement and reconstruction. So on the next slide, I will show you a video which shows a patient who underwent double valve replacement. That means mitral as well as tissue valve replacement in the aortic and mitral position and developed prosthetic valve endocarditis. So I'll show you how it looks like intraoperatively. So this is after doing aortotomy. So you can see the surgeon holding the valve and cutting the sutures using a blade. Okay, so you cut it carefully, getting more closer to the sewing ring so that you will not damage the surrounding tissue. The aortic valve is explanted. You can see the vegetation, okay, on the sewing cuff area mainly. All right. Then surgeon will continue doing extensive debridement, okay. Then you'll go and open the dome of the left atrium, and as well as the infection was involving intervalvular fibrosa. Then you have to cut that one also, so you can see the vegetation. You see that soft tissue is the vegetation, so that will be removed, and then we continue removing the mitral valve. This is a video which is taken from a commando procedure, because after doing this excision of the infected valve and extensive debridement, you have to do reconstruction. So the reconstruction is a different one, because we are not only replacing the valve, but we have to also reconstruct the intervalvular fibrosa or the aortomitral curtail, because the infection is very severe one and aggressive. So that's why it involves all the surrounding tissue. So this is the mitral tissue valve which is infected as well. So once we excise the valve, we do debridement, then the next step is reconstruction. So those debrided areas, okay, have to be reconstructed using a synthetic patch or autograft or homograft or a pericardium. That will be glutaraldehyde treated one. So once we reconstruct the area for valve replacement, the next step is how do you replace it? So the preferred approach is for us to do orthotopic valve replacement. That means we put the valve at the area of the annulus. But sometimes it may not be possible because the tissue is so fragile that we can't really hold stitch. So we need to do some translocation. That means we'll offset the valve from the annulus. So depending on what structures we have, okay, which valve are we operating on? Okay, so if we do translocation, we have to translocate in such a way that the valve will be pulled towards a less pressure area so that patients will not develop aneurysm. So now patient has developed prosthetic endocarditis, either he has underwent tissue valve replacement or mechanical valve replacement. So what should we do? Now, because as I told you previously, figures are telling us that tissue valves tend to have a higher risk of prosthetic endocarditis. But still there are debates with regard to the choice of prosthesis. Some say still because they just continue doing tissue valve replacement. Others say mechanical valve is good. It has got a better resistance for infection. So there is no consensus so far. So, but personally, in our setting in Ethiopia, I personally suggest mechanical valve as after seeing a number of patients. So you can see even our research on contemporary outcomes of rheumatic arthritis surgery in sub-Saharan Africa. Okay. So the other thing is now the patient has developed prosthetic endocarditis, and at some point patient can develop cerebral embolism. What should we do? Because this is the usual scenario. When should we intervene? The earlier is the better. Now in this graph, you can see, if we do the operation within 1 week, okay, within 1 week, you can see the green one, okay, they have got a better survival. If we do the surgery after first week, okay, up to 40th postoperative day, initially they will have a good, survival, but later on it dips down. If we don't do any surgery, they will just follow the natural course or the natural history of the disease of the patient. We are going to lose the patient. So that's why, time is very important. So, the best thing is to prevent development of prosthetic endocarditis. The best thing is to do is to give them prophylaxis. So we have to give them antibiotic 1 hour and as well as 6 hours after any form of intervention procedure, which violate any form of epithelial or mucosal structure. So the drug of choice differs depending on the setup where we are working. So we can use either amoxicillin if it's an outpatient, okay, not penicillin allergic, okay, we can give them PO. If it is hospital setting, and if the patient is having penicillin allergy, we can give them clindamycin, and the other is teicoplanin if it's available. The other is vancomycin is there. So the choice depends on actually our sensitivity pattern within the country. Okay, so I'm going to finish my presentation by showing you one hilarious movie. So you see it and you have your own take, but it will show you also the ugly truths sometimes, consulting, for a given case, which we have never seen before, a complicated one. So what's going to happen? I will show you that video, enjoy it, and then I'll thank you for your attentive listening. So he's going for consultation for his senior in the middle of the surgery. Look what's happening inside the OR. Sorry. Sorry, I have to replay the back, sorry. Okay, thank you so much. That's all we have for today. Thank you for your participants and as well as organizing committee. Thank you so much.
Thank you very much, Dr. Shibikom, for an excellent and informative presentation. We have participants raising their hands. So Dr. Tiasabao, you can ask your question, or unmute your mic and please ask your question. Tiasabao, you can ask your question. Okay, maybe until Tiasabao is able to do that, Helena, you can unmute your mic and ask your question. Okay, until our participants are able to do that, maybe I will forward the questions that have been asked on the chat box. So the commonest question was duration of treatment with antibiotics after debridement and reconstruction.
All right. So after you do surgery, still you have to continue the antibiotic management. So that will depend on your culture result. The good thing with surgery is that you have got a specimen at hand. Okay, you take the vegetation, you take the valve, so diagnosis will be more accurate. Okay, with regard to the type of microorganism causing the prosthetic endocarditis. So once you identify that one, then the other algorithm will continue. So minimum, we will give them at least 4 6, if not more. So the basic principle of management with regard to the antibiotic, whether you do debridement or not, it doesn't differ. So as I've said previously, vegetations are bigger and they tend to involve the surrounding tissue. And the bacteria are more clever. So still the duration of treatment is longer one. The fact that you are doing debridement doesn't mean that you shorten the duration of treatment. Still, you stick to the initial principle of management. I'm not sure whether I have at least your question or not. If it needs further clarification, you can ask them.
Thank you. I think they will write it on the chat box. So the other question is, you have described about the survival benefit of doing early redo surgery. So is there any difference in case of preventing reinfection? So is there any difference in timing of the redo surgery with regards of reinfection in patients with prosthetic valve endocarditis or maybe native endocarditis with an indication to do surgery?
Yeah, now you have to show 2 things here, okay? The figures are mainly the initial one is mainly for a patient who is having native valve endocarditis. If you take them for surgery, mind you, now this patient has got an identified microorganism and has completed or is taking full course of treatment. So in between, he required surgery. The risk is around 5%. But if the microorganism is not identified, or the patient didn't take a full course of treatment, then risk is more than 5%. Now we took the patient for surgery. We did, extensive debridement, okay, and reconstruction. Still the risk is there, but there is no specific figure for that one because as I've told you previously, we are short of data, okay? We have to really come together, whatever we are doing, then we see the patient on follow-up and we see what's going to happen. Now, I'll just give you my personal experience. During my stay as a cardiac surgeon in Ethiopia for the last 5 years, I have done around 8 patients who have got native valve endocarditis. We are still following them. None of them have developed any form of prosthetic valve endocarditis so far. But with regard to patients who doesn't have any form of endocarditis, and there are patients who develop prosthetic endocarditis, and the outcome is really bad. So to tell about really figures, we have to come up with data. We have to really increase our numbers. Then we'll be in a better position to tell about the exact risk of developing any form of infection. Thank you.
Thank you very much. Maybe let's go back to the participant who has raised their hands. Siasbao, can you ask your question now? Okay, let's go to Rodas. Rodas, can you ask now? Can you please unmute your mic and ask your question?
Can I give just a quick comment?
Yeah.
For those who really want to ask, you have to go to your control panel and you have to reset your audio setting. So your microphone might have been disabled there. So that's why even if you unmute on the Zoom, then you may not be able to, give questions directly here. Because you have to go to the control panel, reset on the audio setting. You have to make the microphone setting on. Then with that, we can hear your question actually. Thank you.
Okay, maybe they can also write it, and I will read it for them. So the other is they wanted to ask your experience on what are the commonest causes of redo surgery after valve replacement in our country.
The main issue in our country is compliance issue with the mechanical valve. So they tend not to take warfarin, then they come with stuck valve. Some of patients do well with thrombolytic therapy. What is available and what some of patients can afford is only streptokinase. So we put them on that, then it will get lyzed. Even if it's not lyzed, we'll continue with anticoagulant treatment with heparin and as well as warfarin. Then at some point it will open up. So the majority of redo cases in our setting are due to non-compliance because of warfarin, then the valve gets stuck because of thrombogenesis. The other is the unfortunate ones are those who underwent tissue valve replacement. Okay, in the tissue valve, either it's due to prosthetic endocarditis or degeneration of the valve. As early as 3 years. As early as 3 years after surgery, the valve has degenerated very bad, and then we take them for redo surgery. So those are the areas.
Thank you. There is one question about the benefit of adding gentamicin and what would be the duration of gentamicin in patients with prosthetic valve endocarditis.
So with regard to gentamicin, usually it is for 2 weeks because of the issue with renal dysfunction. And the other thing is when we are combining vancomycin plus gentamicin, risk of renal failure is very high. So don't follow only creatinine level. We have to really calculate creatinine clearance. And we don't have to just keep on giving, with the patient having drop in his creatinine clearance. So we have to really involve, if possible, the nephrologist as well. If not, you can just make further reading, but the duration is for 2 weeks. But we may be obliged to stop or to decrease the drug dose depending on their creatinine clearance actually.
Thank you. So there is one participant who is interested to know what was the culture result of the patients you presented to us.
Oh, okay. The patient actually, he was started with antibiotic treatment here. So we didn't get any culture reports. It didn't turn out to be positive, but I have got no idea the culture report back in India, actually, because it was a really hectic situation for the patient. It was very difficult to convince him. Later on, taking samples and everything, convincing him for antibiotic treatment was also very difficult. So he was taking time, and the disease was very aggressive. So I don't have data on the culture reports with regard to the one which is done in India.
Okay, thank you. Maybe a few more questions on. So, as you said, persistent bacteremia is an indication to do surgery in endocarditis. So, the question is, when should we do culture to say persistent bacteremia in patients with endocarditis?
So, and once we decide that the patient is having prosthetic valve endocarditis, we have to do culture before starting the empiric treatment. Then we'll take 3 cultures, okay? Then the culture will come either after 3 days or after a week. So we continue our empirical treatment. But during our treatment also, we continue taking cultures every 24 to 48 hours. So we check for culture. So if continuously being positive for 1 week, there is continuous high bacteria. So that means we need to remove the focus for infection. That means we have to take them back to surgery.
Okay, thank you. Maybe one last question is the issue about thrombolysis in patients where they have prosthetic valve thrombosis versus endocarditis is considered. This might be a case which is difficult to treat. So what would be your suggestion on that, the timing of thrombolysis?
So if patient is having prosthetic valve endocarditis, there is no place for thrombolysis at all. So we have to change our oral, or that is oral anticoagulant. What we have here is warfarin. We have to stop it and start them with heparin. So if we give thrombolysis for those patients, we are increasing the risk of septic embolism, and that will make the outcome even worse. So we are actually helping in the pathology to get more worse. So there is no place for thrombolysis if patients have got prosthetic valve endocarditis of whatever reason. But without any infection, if they don't develop infection and it's just a stuck valve, the earlier the better, actually. Usually, unless in other words, the patient having panus formation, those patients, the earlier ones, within 1 year of surgery, if they develop a stuck valve, usually the presentation is quite dramatic. They tend to develop all the symptoms of heart failure, obstructive ones. So in such patients, you have to take them right away for thrombolysis, depending on other parameters, actually. Load of the thrombus, any associated factors, we have to really evaluate. We don't have to only focus on lysing that given thrombus. We have to see other parameters as well.
Okay, thank you. Are there any other questions from participants? And so at the part, please use this chance to register on the form to get your CEU points. So one last question would be, there are 2-3 questions about when to consider fungal infection and in patients with endocarditis, especially those that are not responding to antibiotics.
With fungal infection, the first thing is, we started them with our empiric treatment. Let's say the culture is negative. Yeah, that's the usual scenario. Then we started a combination of 4 drugs. Then still the patient is not doing well. Clinically, the parameters are not really settled. So in such cases, one thing we have to consider is either different kind of bacteria or it could be a fungus. The other thing is when we are combining drugs, a risk of fungal superinfection is high. So we have to see our echocardiography finding. Is the vegetation increasing in size? It may be due to resistant infection because of a bacteria, or it could be a fungal infection. The fungal infection, the vegetation due to fungal infection tends to be bigger. So when we are having bigger vegetation, we have to still think of fungal infection when the vegetation is bigger. And the other thing is other, immunostatus and everything has to be considered. So we have to see the patient as a whole rather than just focusing only on the valve pathology. So by adding all those things, we have to come up with a good clinical judgment. Then we can decide on further management of that patient.
Okay, so thank you very much, both the presenters. It was an excellent presentation. Thank you, our participants. We would like to extend our gratitude to both the Ethiopian Society of Cardiology and the ENAOC team for giving us their platform to present and do this. For the past 3 weeks. We had 6 sessions. So this is the last of the pre-CME sessions, and thank you very much. Thank you for participating actively. We would send your certificates, both certificates, via email, and please give us a few weeks so that we can get time to do that. As I said earlier, the recording would be available on YouTube in a few days. Thank you very much, everyone. Have a good day and happy holidays.
Thank you very much.
Thank you.
Have a nice time.